Thanks. I think Chris has given you a fantastic introduction, both in terms of the general sense of what happens at ASCO, as well as a really fantastic wrap-up of some of the key colorectal messages. I'm going to, you ready to go?
This is just going to play in the background.
Yeah, perfect. Yep. So I don't have slides specifically to refer to, but I was going to briefly share my ASCO impressions. I think it was my 10th ASCO actually this year. Most of them have been in Chicago. I think my biggest tip that I have learnt is having a properly located, decent coffee shop, particularly in the mornings. I'm never a morning person, but with the jet lag and the trying to get to breakfast meetings, my current hotel preference is based on the fact that there is a very nice coffee shop nearby that I've discovered that does decent, proper, what we would call coffee, not what Americans would call coffee, which is something more akin to dishwater. So that's been my biggest ASCO tip. But as Chris said, I think the reason we often congregate as Australians is because there's usually only one decent place to get coffee and everyone's there trying to stave off their jet lag. But also because we're very collaborative. And that's always one of my highlights is talking to our collaborators, which we did quite a lot of this meeting, and also getting their impressions on what's going on at the meeting. So it's always feels a little bit like nerd boot camp. Oncologists and for clinical trialists and researchers across the spectrum, but it's just a fantastic opportunity to bounce ideas off other people, and I always come back quite enthusiastic as well as quite exhausted. So it's always a challenging week or so afterwards trying to get on top of things. But I was asked to speak on sort of some focal key messages in upper GI cancer. And actually, while there weren't any sort of major plenary sessions on GI this year, the actual GI oral sessions had quite a mix. In fact, I think one of the speakers' summary talks was a potpourri because as you would be aware, when we talk about upper GI, or what they call in the meeting non-colorectal gastrointestinal cancer, that actually includes a bunch of different cancer types. So at ASCO that usually includes pancreas cancer, gastric cancer, or esophagogastric cancer, esophageal and gastric, liver cancer, bile duct cancer, and small intestine kind of gets lumped in there, but often other sort of rarer tumour types. And this year they had studies on some neuroendocrine tumours, which can be found in lots of different parts of the body, but are commonly found in the gastrointestinal tract, and so got put in there as well. So it was quite a mix. So I'm going to just do a selection from amongst those talks because there's really quite a lot to try and take in and sort of explain. And I think the ones that are going to potentially affect practice and also that informs some of our current and future trials are probably the keys in terms of thinking about what the changes to practice are going to be. I think the scale of the meeting is both encouraging in terms of the extent of research and collaboration that's going on, but also, I guess at the same time, quite confronting both in terms of the practical aspects of trying to navigate a 40,000 person setup, but also recognition that cancer is such a global problem that we've got proportion only, and it's a significant proportion, but even just a proportion of the sort of international workforce attending, and it's that many people. So I'm going to focus on some of the trials that will probably already be changing practice in the last few days in terms of what people will do in the clinic, but also I think in both a positive way in terms of new things that we now have to offer, but also important negatives. So in a similar way that Chris talked about some negative trials, things that got an answer, but the answer was not what we expected. Even though people and the media like to talk much more about the things that were positive, the new things, the things that were better, equally the things that are definitively not better can also help inform our practice. And I think that's also important to talk about, and not just talk about the new, better, shiny things. So I wanted to talk about 2 trials in pancreas cancer. One of them garnered a fair bit more attention than the other, at least on social media. But I think both are quite important in terms of the shifting paradigm of how we manage pancreas cancer. And AGITG has done some recent trials that fit very well, or at least ahead of that paradigm. And these trials one of them at least supports the need to change the way that we approach pancreas cancer. So the Protégé trial has also got a couple of other acronyms because it was a collaboration of several groups. But this is a trial that was led in France by their collaborative group, and it basically took people whose pancreas cancer was considered to be what they call traditionally resectable, so able to be completely removed or expected to be completely removed at surgery, so confined to the pancreas and maybe some of the lymph nodes in the area, but not involved with any of the local structures, blood vessels and things that might make it complicated to get it all out. So in people who had gone through basically a Whipple's procedure or something similar, and were fit to start chemotherapy after that, they were given one of 2 different types of chemotherapy. And the standard treatment, which until last year had been the standard treatment for many years, called gemcitabine, which is a single drug given intravenously 3 weeks in a row on one day and then a week off for 6 months. So they got that treatment, or they got the newer treatment. And there's a few caveats about that newer treatment. They did this trial on the basis that the newer treatment, which is referred to as modified FOLFIRINOX on the sort of acronyms of the 3 drugs it contains, which is 5-fluorouracil, oxaliplatin and irinotecan, all of which are drugs that have been around for some time. They took that trial from the advanced setting. So they've previously done a trial that was published a few years ago that showed that compared to gemcitabine in people with established metastatic or stage 4 pancreas cancer, that the combination treatment is more effective than the gemcitabine. So they then decided, well, if it's more effective in people whose cancers are established, it helps them live longer and feel a bit better for longer, then we should see if it works better at mopping up the cancer than the standard treatment. The caveat on that being that 3 drugs, as you would expect, is a lot more toxic than just the one. The patients that would have been put into this trial, and there were about 500 of them, are people who are going to be probably a lot fitter than some of the other trials that have been done in the past in this setting, or certainly a similar trial that was reported last year that just looked at a combination of 2 chemotherapy drugs, the gemcitabine plus an oral version of the 5-FU called capecitabine. So in sort of trying to tee the numbers up, because the numbers looked a lot better for many patients in this trial, it's important to sort of keep in mind that people who've been through a Whipple's procedure are often very unwell, and in this trial they did allow them 3 months to recover before they had to start their chemotherapy, because it often takes that long. But people who are fit for having 3-drug chemotherapy is certainly not going to be everyone. So while there were some very impressive results, and they found that the actual survival of patients who got the 3-drug combination was quite a lot more, not quite double, but at least 1.5 times longer. And also the time until the cancer came back was a lot longer, which is also important. While that was the case, this is not going to be for every single patient that is going through that procedure. I think what it also supports, and not surprisingly, there were a lot more side effects in the people that got the triplet combination. What it also supports, though, is the fact that systemic therapy for pancreas cancer is an important part of treatment. And the traditional approach, which this trial took, which is that if you can cut it out, you cut it out first and then you give the chemotherapy, is still a very reasonable thing to do. But the significant gains in survival by sort of upping the chemotherapy certainly make the the timing of the chemotherapy, also a really valid question, and that's the next trial I'm going to talk about. Treatment about pancreas cancer, and keeping in mind that, as we said, only a small proportion of patients will be suitable to have an upfront surgery at the time that they're diagnosed. There's another proportion of patients who will have what's called borderline resectable disease. So disease where you wouldn't necessarily want to go straight in and cut it all out in case you left a bit behind, but you think that you might be able to. So there's a little bit of uncertainty, not clearly going to get it all out, but certainly you might need a bigger operation, but potentially could take it out. And the difficulty in that sort of definition and asking for details, and the reason I won't go into it, is that there's lots of different places in the world where they disagree on some of the minor details about how you determine whether it's completely resectable or not immediately resectable. But the trial called PREO-PANC, I love all the acronyms, so basically pre-op with pancreas cancer, they took patients that were in theory fit and suitable to have their pancreas cancer cut out immediately, as well as some patients where they had slightly more cancer than that, but not so much that you'd say the surgery would definitely not be an option. And then randomise them either to have standard treatment, which is the same sort of standard treatment in that previous trial arm, so surgery and then 6 months of gemcitabine chemotherapy, or they gave them what we call neoadjuvant treatment, so treatment prior to surgery. And the treatment was a few cycles of gemcitabine, and then gemcitabine combined with a short course of radiation. So a little bit shorter than what people often give for radiation when there's not any surgery planned. So it's 36 fractions and a sort of slightly smaller dose, but nonetheless they got those two treatments and then surgery and then a bit more chemotherapy. So it was kind of splitting up the chemotherapy to before and after the surgery and then adding in some radiation before the surgery. And that's actually an approach that is done or now done in a lot of other cancers on the basis that we know that the problems with having some of those treatments after surgery is that often people are very sick and they can't have the treatment. And if it's the treatment that's benefiting them, then they potentially do worse if they miss out on having the chemotherapy afterwards because they can't have it at all. So giving it beforehand, often people cope with it better because they're not struggling with post-operative recovery. And the caveats in terms of the potential cautions around doing it beforehand, because you'd say, well, why not just do it all beforehand then if that's the case? There's always a couple of concerns, and one of which is that the surgeons get a little anxious about the potential increasing complications from operating on tissues that have had radiation and chemotherapy affecting them, particularly the radiation. And the risk of increasing the side effects and the complications with surgery. And also the other concern that often patients have is that the cancer might progress before they get to surgery and they wouldn't get the surgery. And both of those are reasonable concerns, and one of the appropriate reasons why we need to actually do clinical research. We need to look at what actually happens in reality. And what this trial showed is that definitely in the borderline resectable, but also in the people who were immediately resectable, they did much better from having the preoperative treatment in terms of some initial results about the time until the cancer came back, and also some slightly immature results, so needing a bit more follow-up, needing a bit more working out what happened to those patients, but in terms of overall survival. So both of those things are very, and safety results were not significantly compromised. The other thing that I thought was really interesting in that setting is that they saw that despite the fact that actually a smaller proportion of patients, only just, but about 10% less patients actually got to surgery in the group that had the neoadjuvant treatment first, which actually sort of speaks to the fact that surgery is possibly a bit less important than a lot of people think it is in pancreas cancer, and that the pancreatic cancer is a cancer that tends to spread early, so it doesn't necessarily have to grow very big before it wants to shoot off elsewhere. So the role of and the timing of systemic therapy in pancreas cancer is something that we we need to keep working to optimise. And some of the current and planned AGITG trials that are working on moving the treatment earlier and the best treatment, I think are even more interesting in light of this research, because the chemotherapy that was used in this trial, the PREOPANC trial, is the standard gemcitabine. And we know that, and that's because when the trial started years ago, that was the best chemotherapy. But we now know that we've got the triplet combination, the FOLFIRINOX, that works better in the advanced setting as well as the adjuvant setting, as well as some degrees of combinations in between that probably have slightly better activity than gemcitabine alone, with maybe not as much toxicity as FOLFIRINOX. So these sort of trials are likely to change practice in a lot of centres fairly immediately, but also I think raise other questions, which is, well, we've got information to suggest that we can potentially do better. We should be doing the next lot of trials to improve on that situation further and work on things with the newer treatments and the newer radiation techniques, which is the other thing that, that is emerging. So I thought those two trials together were, on the surface of it, potentially conflicting. You say, well, you've got these two trials. One says do surgery first, then do chemotherapy, and the other one says don't do surgery first, but give this other treatment. You could say, well, which way do we go? They're both actually good trials, and I think the reality is that you can potentially do either. And we will be having a very interesting discussion in our Alpha GI MDT on Monday, I have no doubt. Our surgeons are always asking us, when's the next trial, when can we put people on? And with that in mind, we're also eagerly awaiting the results of the GAP trial, which is a AGITG trial that looked at a similar population but just one arm and looked at slightly more modern chemotherapy. So we're hoping for some updated results on that soon. And there's also another trial going on that Australian people have recruited to, not an AGITG trial, but that looks at a slightly different treatment given after surgery. So there's lots of things that we still don't have answers to, but we've got lots of potentially better options for our patients as of, straight away, which is encouraging because we need them in pancreas cancer. So I was delighted that there were several different trials in pancreas cancer, and initially a little bit puzzled about how to put them together, but it certainly was encouraging. This year there was one of the plenaries was in genitourinary cancers, in kidney cancers, and it was looking at whether or not you actually get a benefit from taking out someone's kidney if they've got metastatic disease and they're having, if they're having good modern targeted therapy, because they'd had some previous research to suggest that with some of the older style therapy you did get a benefit, but no one knew the answer. And the trial was actually led and presented by a genitourinary surgeon, a urologist, and who basically said, some of my colleagues thought I was crazy for doing a trial that potentially shoots our practice in the foot, and he actually had a lovely cartoon of, speaking in his French accent. But he said, but it's critically important to answer these questions. We need to know. And that trial actually found that there was basically no benefit for the type of patients they put in the trial from taking out their kidneys, which is actually a really important thing to know. And most surgeons actually don't want to operate on people, particularly if they know it won't help them, because they understand better than anyone the risks of doing it. And one of the ways that we manage most cancers, or part of the process, is through multidisciplinary team meetings. They sort of function slightly differently in each centre, but effectively all new cases of pancreas cancer in my centre are discussed through the MDT, and the surgeons that we have working with us have sufficient expertise and caseload to be a centre for managing pancreas cancer. So the first thing would be to say that not any surgeon should be operating on pancreas cancer in the first place. That would be the criteria. And they should always be part of an MDT in terms of making those decisions, which tends to be the practice, at least in the places that I've worked and currently do. Surgeons are an important part of the decision making, but they need to be up with the evidence as well. So like I said, we'll be having very interesting discussions on Monday. We've already circulated some of the abstracts, and we do that regularly when we come across things at our respective meetings or journals and for discussion. My argument would be that if you have colleague who doesn't listen that they should be gently educated into the fold, and if your surgeon won't discuss current evidence, then you should find another surgeon. But yeah, so well, they're as much cancer treatment as, you know, they need to know the place of surgery as much as we need to know the place of chemotherapy, and I don't give radiation, but I need to know the place of radiation as well. So my surgical colleagues are actually always asking for when's the next trial coming that they can put people on, because they know how many unanswered questions there are in pancreas cancer, and at our centre we consider appropriate clinical trials as the best form of treatment for patients where they're available. And that's consistent with best practice. So the discussion I'll be having on Monday will always be, you know, first of all, is that a suitable option for the patient? Are they fit for it? And then we'll be having some discussion about whether or not they're better off having more treatment beforehand or having more afterwards. And one of my criteria for deciding would be their general fitness, because the first trial I presented is really going to be a fairly select group of patients. It's a chemotherapy regimen that we do sometimes give in other types of cancers that are very advanced, so we have experience with it, and it's definitely not for everyone. And so, yeah, if people are assuming they're going to get those benefits, but they never get to the chemotherapy after the surgery, that may not be a better outcome. So we'll be having discussions about that. There's always the technical considerations with pancreas cancer. We talk to our gastroenterology colleagues that do the endoscopic ultrasounds, you know, what vessels are involved. We've got specialist radiologists. So all of those usual considerations about can we get it out and can we get it completely out, but knowing that if not, or if there's any questions, we know now that there's some better options, or at least good options for giving treatment before surgery. And so that adds an option for many patients, which is exciting. I might move on. So my last talk is going to be, or actually two last talks are slightly different, and they're more about gastric and gastroesophageal cancers, so stomach cancer and esophagus cancers. And one of the reasons why I wanted to talk about the Keynote 61 study is because it wouldn't be a cancer talk these days without some immunotherapy creeping into the mix. But actually, more importantly, because it references my comment about the importance of actually having trials that are definitively shown that something doesn't work. And the importance of doing proper clinical research and not just making assumptions from lab tests and early trials on how something's actually going to work in a group of people. Is this trial basically demonstrates what a lot of people had been suspecting, which is that even though immunotherapy for gastric cancer can help in some circumstances, it's not going to help in all. And it certainly doesn't seem to help anywhere near as much in stomach cancer as it does in other types of cancer. So this trial, Keynote 61, was done in a bunch of different countries, including some investigators from Australia, but it was a pharma-led trial. And all the patients going into it had to have had some chemotherapy already for their incurable gastric cancer, so they all had to have stomach cancer that had spread, or cancer from the esophagogastric junction, so the join between the esophagus and the stomach. And all the patients in the trial had to have had what we'd call a fairly standard combination of at least 2 drugs to start with, and that they'd either stopped responding to that or stopped tolerating it. And the treatment they were given in this trial of about 800 patients was selected down to either standard treatment, which is a different chemotherapy called paclitaxel or Taxol, that's given 3 weeks out of 4, once a week as a drip, or they were given one of the newer sort of immunotherapy drugs called pembrolizumab, which is given as 1 drip every 3 weeks. And we know that some related immune compounds seem to have some benefit, although not a huge amount, when they're given after 2 different lots of chemotherapy has stopped working and when they are compared to sort of no treatment at all. So they sort of said, well, if it's a little bit better than no treatment at all and it's quite safe, let's see what happens when we do it instead of chemotherapy, because we think it's going to be better. And that's not in fact the case. So not only was it not better, or not better enough, didn't make any difference to how long people stayed alive or how long until their cancer grew in any meaningful fashion. But for some patients who were defined as sort of not having any expression of a biomarker that might encourage a response to this treatment, but for those patients there was a suggestion that actually they did better on the chemotherapy. There was a bit of tweaking, a bit of trying to work out, well, is there a group of patients that did actually get benefit from the treatment even though it's not the original group we thought, and maybe some people who have particular types of cancer, including those that are more likely to be related to Lynch syndrome or underlying genetic defects, maybe they get a little bit of a response and a little bit of a benefit. But for the original group that they selected out who had some evidence of this biomarker, they didn't seem to do any better. They got some different side effects, but and they were all consistent with what we know about immune therapies. So fatigue, colitis, diarrhea, hormone upsets, a bunch of things. They didn't get the side effects associated with the Taxol, but nor did they get any meaningful benefit. So that was what I call an important negative. There was a lot of hype around immunotherapy in general, and always a lot of hype about this trial when it sort of originally set out. It recruited very quickly relative to what was going on because everyone was excited about immunotherapy, but it doesn't seem to be any better. So that's important to know because we don't want to be offering people something that doesn't really help them. And also, apart from the toxicities, it has other toxicities, including the kind of incredible expense. So, so that was an important negative. But another important positive, which is actually about prevention, and I'll just mention it because it was an astoundingly well done study. But we know that a number of people who have gastroesophageal junction, so at the end of the swallowing tube cancers, that actually arises from a condition called Barrett's esophagus, which can be associated with sort of reflux and similar signals into the lining of the esophagus that with time can turn into cancer if it's left. There's been a very, very large study done of 2,500 patients followed for about 9 years average. So the total study, and from when they started until they reported this, was 19 years. Big study looking at patients who have Barrett's esophagus, who are high risk for developing esophageal cancer. Can we prevent that? Can you reduce the chances of them getting cancer? And they showed that they looked at two things. They looked at aspirin, and then they looked at 2 different doses of a proton pump inhibitor, which are drugs that are designed to sort of reduce acid in the stomach and potentially reduce reflux. And they showed that when you give a high dose of a proton pump inhibitor, as well as then combining it with aspirin, you get the biggest effect, and you can potentially reduce the number of cases by enough to warrant potentially doing that without a lot of side effects. And they also showed that the aspirin alone didn't do very much, and that the low dose PPI did not a huge amount on its own. So the 2 bits together were the key, and the adverse events were actually really low, so less than 1% of patients. Because always we do worry about giving people drugs that can have side effects, even if they're relatively mild. If you're going to take them for that long, for that amount of time, forever, basically, then you worry about the side effects. So, yeah, it was an incredibly impressive effort from the patients and the study team, and I think is really encouraging because it means that we might be able to prevent people getting esophageal cancer, which is, definitely a good thing to prevent. So, so I was very encouraged about that, even though it wasn't a traditional chemo drug. It's certainly chemo prevention in the best possible way. Yes, and that will likely start to change practice immediately as well because we have access to both those things.